Barakat. Okay.
I think Barakat ወጥቷል. ራሱን
ወጣ እንዴ? Okay.
Yeah.
Start ስትለን እንጀምራለን። አንቺን ኢንትሮዲዩስ አድርግሽና ቤትዬ።
እሺ። ኦዲየንሱ ሞስትሊ አነስቴዚዮሎጂስት ነው ወይስ ጀነራል ፕራክቲሽነር ነው?
ጂፒዎችም አሉ፣ አነስቴዚዮሎጂስትም አሉ፣ ሬዚደንቶችም አሉ። ለእነሱ ነው ሼር ያደረኩት እኔ እና ኢትዮጵያን ዶክተር ናም ኮቪድ-19 ግሩፕ አለ ፌስቡክ ላይ፣ እሱ ላይም ሼር አድርጋለሁ።
እሺ። BCG ካምፓኒ ምንድን ነው? I'm just curious.
ቆይ በረከት ያስረዳሻል እሱን more.
Okay. Hello.
Hello ቤትዬ። እኔ እና አንቺ ነን ያለነው መሰለኝ. Let me just ቆይ WhatsApp him.
እኔም አለሁኝ።
ሰላም
እኔም አለሁ። ሃይ ረን እንዴት ነሽ?
እግዚአብሔር ይመስገን። ደህና ነሽ?
አለሁ እግዚአብሔር ይመስገን።
Ready, I think ጀምሩ ብሎ ቻት አድርጎልናል።
የታል? Okay.
ቻቱ ላይ ስታርት ብዬ ጀምሩ ብያለሁ ግን እኛ ጋር እዚህ ጋር አይታይም. But it's okay, let's start. I think I don't know which chat ላይ እንደጻፈው እዚህ ላይ አልጻፈውም ግን
እሺ በቃ I'm just going to start live ላይ ነው ይላል። እሺ Okay, go ahead. Start. So start ላደርግ ነው በቃ።
ጀምሪ።
እሺ. So good afternoon everyone. Today we have an anesthesiologist from University of California, San Francisco. Her name is Dr. Betelehem Asnake. Her name is Dr. Betelehem Asnake. She is a COVID OR set up in acute responsive co-lead in her hospital. And she will be presenting today COVID-19 and anesthesia implications, basically how we should go about setting up COVID OR and related to OR, anesthesia and COVID-19 implications. Thank you, Dr. Betty. You have the floor now. Continue.
Hi, everyone. Thank you so much for inviting me to this talk. As you can tell, my name is Abisha. I'm Ethiopian. But I'm just thank you so much. So the focus of this talk is COVID-19 and anesthesia implications. And this is very anesthesia focused and anesthesia heavy. So if, you know, even if you're a general practitioner, I think you'll find something that might be useful for you on setup in your own practice. The reason why I wanted to focus on this talk is because I am one of the co-leads for the COVID OR setup in my department. And I'm also the co-lead for the anesthesia, the COVID acute response team as well. So I have some, you know, some things to share. I understand as we're going forward, a lot of the things I'm going to talk about might not seem applicable to the setting of LMIC and low resources, but I've tried to include some things that would apply in your own setting as well. So I have no disclosure, I have no conflict of interest. My objectives, we're going to start first by highlighting the critical position of the anesthesia provider in managing the pandemic. We're also going to highlight anesthesia in the operating room being a milieu for infection spread. We'll discuss the process of creating an operating room setup for COVID positive and PUI cases. And then we'll discuss the special consideration during airway management of COVID positive and PUI patients. And then at the end, I'll share some important anesthesia workflow changes that we've done in our department in response to the pandemic and in response to decreasing infection rate. So first, I'm going to start by saying anesthesia is a conducive environment to exposure and spread. The reason why is because we manipulate the airway. So we create and we expose ourselves and other providers to aerosols and droplets, especially in COVID positive patients. We place lines, we do procedures where we have to touch the patient on a regular basis and constantly. We do operating room cases. So that means we're in the operating room for sometimes many hours with patients who are infected. So our infection risk goes higher as we spend more time with the patient. And then we use various equipments. So the fact that we use equipments is already a risk of contamination from the equipment to the patient, to other staff members, and to ourselves. On the other side, the operating room is also a milieu for spread of COVID-19. So these are some papers I briefly took out just to mention a few key concepts. On the left side here is a paper from Analgesia and Anesthesia, and this was from 2012. This is an old paper, and it's looking at the operating room as being a reservoir for intrabacterial transmission. And one of the main things they found out is here. They said bacterial contamination of patients, providers' hands, and environment contributes to staphylococcus transmission events, but the surrounding patient environment is the most likely source. So they looked at patient infection with Staphylococcus aureus, and they looked at where it was coming from, and their conclusion was it was coming from the environment. So the operating room environment is even the environment itself is conducive for bacterial growth and virus growth. Here at the bottom, it's a recent paper from a few days ago that came out. It's looking at aerosol surface stability of SARS-CoV-2 and SARS-CoV-1. They actually looked at CoV-2, and this actually, CoV-2, and they said the half-life and how long the virus stays on surfaces is very long, up to days, and it can be viable for days. And how, if you bring someone in the operating room, you can have the virus alive for a long time, possibly infecting other physicians, other providers, other patients as well. And then this is another paper here that looks at aerosol generating procedures and risk of transmission to healthcare workers. And any healthcare worker who is in the vicinity or in contact of an aerosol generating procedure in a COVID positive patient has an increased odd risk of 6.6. So you're 6 times more likely to get infected compared to other providers. So all in all, to say, anesthesia itself is a risky field for infection, and then the operating room itself is a milieu for infection. So when a pandemic like this happens, the hospital has to respond in a way to bring a solution. And for us was how to provide safe, effective, and timely anesthesia care with minimal infection spread to other patients and other staff. So we were tasked to designing a COVID positive PUI operating room. And as I said, I was the co-lead. Our aim was to provide safe, effective, and timely patient care with minimal infection spread to other patients and staff. Our work group was 6 anesthesia providers. There's 3 anesthesiologists, including myself. There's 2 nurse anesthetists and 1 lead anesthesia technician. We had multiple meetings with hospital infection control, perioperative nursing, surgery, and anesthesia leadership. And this was a very time-sensitive project. We were told to come up with the final product in about a week. So we quickly had to set up the operating room, set up the workflow, discuss with infection control and other stakeholders in this project, and have the project ready. And this will be the case for you and your hospital and many other hospitals around the world. This is very time sensitive because the patients can't wait, the cases are increasing. So you have to come up with a quick and easy, safe way of managing this. So the first thing we looked at is location. So our main, we spent, I think, I don't know, 3-4 hours debating on the location, just the location of the OR, which OR should be a COVID positive OR. And so our goal was to make sure the operating room that we picked to be an operating room for use for COVID positive or patients under investigations has to be non-central, the location to other ORs. We don't want it to be central because it's high risk of contamination. We wanted it to be isolated with its own entrance and hallway. We wanted it to be low traffic for staff and patients. So we don't want to pick an OR that's busy or like in the middle of a lot of traffic. We don't want it to be close to the designated clean areas. So we had in our hospital some designated clean areas, and we like the pharmacy and the anesthesia supply room. Some of these areas, or the pre-op where patients come in, or PACU, we wanted to make sure it was away from those areas. And if possible, we wanted it to be negative pressure room. And I have here from the CDC website, this is basically their recommendation in terms of how long it takes for like a viral particle or an aerosol or droplet to clear from the OR. So ACH here means air changes per hour. And so depending how many air changes per hour the operating room has, this is the amount of time, the time it takes for the efficient removal of airborne particles. And this is 99%. And then the next one is 99.9%. So if you see, if our operating room air exchanges per hour is only 6, then it will take about 46 minutes for 99% of the airborne particle to be gone, and 69 minutes, which is a long time, right? Thankfully, our OR was about 30 to 40 air exchanges per hour. So in about 14 minutes or so, 15 minutes or so, 99% of the particles will be gone. And in 21 minutes, 99.9% of the particles are gone. This is important to understand because this would lead a lot of your setup. So some of the main things you have to decide in terms of setting up your own OR is understanding your current setup. What do you have in your hospital? What is the current setup? How do you control infection already? And how can you revamp that for your own? So here is reality. So in reality, obviously, we couldn't meet all of the things that we wanted to meet. So we ended up picking a corner operating room. So that we have 14 operating rooms in our hospital, in the branch I'm working at. And we picked one that was in the corner that had somewhat of its own hallway entrance. And then that was away from, as much as possible, away from traffic. It didn't have its own individual hallway or entrance. It has a small area where you can go in and out, but there's still other traffic that went in, but it wasn't the heavy traffic area of like that we wanted to avoid. Our OR is not negative pressure room. None of the ORs are. So we couldn't make the room negative pressure. Some hospitals can get the engineering to come and change the ventilation system in the operating room. We couldn't do that. We were okay that in about 15 minutes, 99.9% of airborne contaminants were going to be gone. So that was kind of the time we gave, is about 15 minutes for patients or staff to not go in after intubation or extubation. So this is for LMIC consideration. So just thinking about your setup for an OR is, it has to be away from main traffic again. It's isolated area, right? You don't want to put it somewhere that's heavy traffic. You want to minimize the cross contamination between your ORs. So if there's a door between your COVID OR and another OR that's interconnected, that's probably not the best OR to use. Or if you do use that OR, you have to seal the door and make sure there's no, unnecessary airflow or contamination that happens. You have to ensure the doors are tight and can close very tightly, because after intubation or extubation, you can't open the door and you have aerosols going into in the middle of of the theater. You clearly have to label the door of the OR as COVID high isolation room, so there's no mistake that other staff members don't accidentally come in. You have to educate the staff and let them know of these workflow changes. And then lastly, if you can, you can look into air exchanges and your current ventilation system for the operating room. So this is an important task to do, and it can be done. We did ours. We had a lot of communication with the operating room engineering. So it was constant emails and understanding what the current setup is. A lot of us don't know how the current setup is. We come to work and we anesthetize, we do cases, and we go home. We don't understand how infection is, how is the environment of the OR preventing infection already at this, with the current setup. And then next was our equipment protection. So we wanted to protect our equipments for many different reasons. Obviously, you want to protect it for longevity. You don't want your equipment to break down for any case, right? You protect your equipment. You want to make sure your equipment is not a fomite. You don't want it to be a place where staff comes and gets contaminated. You don't want your equipment to be where other patients get contaminated because it wasn't cleaned properly or protected properly. So we wanted it to be practical and non cumbersome and easy to use. This is not the time to introduce new technology, new completely like foreign thing to the staff, because in a crisis situation, you don't have the time to train all your staff. It was this new equipment. So stick with what you have, and then try to design something from what you have, rather than introducing completely new concept. We wanted it to be minimalistic. So we don't want to, for it to be cumbersome. So our idea was to, the less is more. So only bring into the operating room the bare minimum, the only things that you need. So if you usually have like 10 different things in the operating room, sometimes our ORs, I don't know, I know also actually in Ethiopia, some of the ORs are the same way because I've seen them. So same thing with our ORs. We have so much stuff in the operating room. Sometimes there's a chair, there's a stool, there's things that are not needed who can be fomites. So clear the OR and make it extremely minimalistic with the bare minimum. So for anesthesia, we took our anesthesia cart outside. The cart itself is outside. We only bring into the OR what we need, and basically the bare minimum. The surgical side, same thing. We had a discussion with them in terms of them bringing really the bare minimum of what they need into the OR. And then you also want it to be easy to decontaminate and clean. You don't want to have a bulky equipment that's not very necessary and it's really hard to contaminate, to clean. So and so for that reason, for us with the ventilator, for instance, is bulky, it's big, but we need it. We can't leave the ventilator outside. So we decided to cover it with a plastic cover with a clear idea of how to disinfect afterwards. And I'll talk about that. And then we had an appropriate disposal system. So for us, it's very important to have a designated disposal system. So after you intubate, your blade, your ET tube, the stylet, everything is contaminated. It's basically COVID particles on your equipment. So you really have to think about how are we going to isolate this and clean it afterwards. So it's very important to have a sealed container or close the system where you put your direct laryngoscopy or your ET tube and seal it pretty much, and then have a worked out way of decontaminating that without affecting the person who's decontaminating afterwards. So this is our final product. So if you can see on the left side, this is our operating room, and usually our operating rooms are very crowded. There's a lot of stuff inside it. So we took basically everything out of the OR except the things that we need. So if you see here, every single thing, the Mayo stand here, the bear hug, the trash cans, the surgical stuff we didn't really go into, but all the other anesthesia things here are deemed extremely necessary by our team. Everything else was outside. Here's the ventilator. So we This is very easy to do. We just put a trash bag, a clean trash bag, over the ventilator. And at the end, I'll talk about how we decontaminate. And then same thing with the pumps. Our pumps are very hard to clean. It's hard to clean each crevices of the pump. So we just put a plastic cover on it. This is our charting station. This is our charting is online. So we also covered our computer. And then here on the side, this is our drawers. So our drawers usually are extremely full. There's a lot of different excess equipment in there. We put one of each equipment in each of the drawers that we think is extremely necessary. And then here is our circuit setup. So we have the inline filter and then inline suction as well. And we can talk about this more. So in terms of decontamination, so this is we worked very closely with the people who decontaminate our ORs, which are for us, our anesthesia techs. Our techs are very instrumental in decontaminating. So what they do is, even when you take off the plastic cover, you can't just take it off the way you want to, right? So if you have particles here, you have to make sure you have a systematic way of even taking out the plastic cover. So what they do is they cut it in half and fold it from the outside in. So they fold it inside. And then even with that, they still clean the machine afterwards. So this is more of a precautionary measure. Even after everything is off, they still clean, but it makes us feel better that at least a lot of the material was not exposed. So for LMIC consideration, you have to decide for your ventilator, do you want to clean it by hand or do you want to cover it? So this is a decision that needs to come up with your department. And then with your usual cleaning process, who does it, how is it done? So a lot of this has to be understanding the current system and the current setup. So you have to understand how your OR is cleaned. Hello, I think someone is unmuted. Yeah, can you please mute yourself? And so you have to understand who's cleaning the ventilator, how it's cleaned, and decide if you want to do a clear plastic covering. Next is the drug storage and trays. So we took our anesthesia cart all the way outside of the OR. We don't want the cart inside because cleaning the cart takes time and there's a chance of not being able to clean it well. So we decided to take the entire thing out and then only bring into the operating room the things that we need. So if you're doing a case, a general anesthesia case, you're gonna intubate, we told our providers, bring the things that you think you're gonna need. So induction medication, paralytic, antibiotic, fluids, and then any kind of pressor if you need some pressors. So we asked them to bring what they need and a syringe that's already pre-drawn. Everything that's already pre-drawn afterwards get wasted. So if you don't bring something that you're not going to use, because if it's in contact, we have to throw it out. So we had a clear communication with our team about that. For you guys, in terms of paper charting, we covered our charting station. It's on a computer. If you're doing paper charting, you have to figure out how you're going to isolate that because you're going to be wearing gloves, you're going to be paper charting, and then it's going to get contaminated. The paper charting is going to go to PACU, or it's going to go to the floor, and then 10 other people are going to touch it, and then there you go. There goes your spread. You know what I mean? So you really have to figure out, you have to be very careful on how you design this process. If you're paper charting, maybe putting the chart in a plastic cover and making sure that everyone knows this is a contaminated piece and that every time they use it, they use gloves. Just, have a system for this. And then this is very important, having a dedicated anesthesia airway disposal system that's sealable. So in our OR, we didn't have any sealed trash bag pretty much. Everything is open. You just throw it and it's open to the air and the atmosphere. And so we didn't want that for our anesthesia equipments. We wanted to make sure it was a sealed container. So we intubate. After we intubate, we double glove first of all. we intubate. After we intubate, we put our first glove over the laryngoscope and we put it in a trash bin and seal it. So like we make sure it's contained. And then another thing is having a dedicated direct laryngoscopy in the room. So we have, for you guys, you know, if you reuse, I know a lot of places you have to reuse the endotracheal tubes. If you're reusing your endotracheal tubes, then just have one or two that's dedicated for that room, so that even if the cleaning process is not the best, your transmission rate is not going to be as much. So have a tube or direct laryngoscopy that's only used in that room to minimize the contamination. So this is just an example of what we did. So because we took out our induction cart, we created our airway kits in plastic bags. These are double Ziploc bags. We did it with our hands, and then we labeled them. So we have the material in a Ziploc, and then we put the Ziploc in another bag. So it's double Ziplocked. And this is basically the emergency airway kit. This is only opened if there's an emergency. So if you have no emergency, you should use whatever airway equipment that you brought in the OR. So if your plan is to intubate the patient, then have the video laryngoscope or whatever laryngoscope you use, have your ET tube, have your rescue stuff that you usually use, and your syringes, that's it. This is only opened if you have an emergency with the airway. So in here we have LMAs, bougie, oral airways, and we had more direct laryngoscopy because we're using, for us, a video laryngoscope. So we told the staff when we were training them, this is only to be opened if there's an emergency. If there's no emergency, don't open it. And if they open it, then everything else in there get discarded for us from our policy. This is our policy with infection control of the hospital. We also made an emergency drug kit. So this is just for us. Obviously, for your hospital, it might be different. For your department, it might be different based on what you have available. But same idea, we put them in double Ziplocs, and then this is only emergency drugs. You only open it if you have to. You have to be able to anticipate the usual drugs that you use for your case. So if you use a pressor of phenylephrine, or if a patient is very sick, is coming from the ICU, and you know you're going to need a pressor or some kind of medication that will increase your blood pressure, then have that set up, right? Have that ready, so you don't have to open this kit and now everything is decontaminated. So for LMIC consideration, again, you know, I think you should create an emergency airway and drug kits in sealed plastic bags and have them ready. Have dedicated kits and tray that stays in the dedicated OR. So if you look at my previous picture, you see the tray here, the Mayo stand. That's basically it. This is very easy to clean. So it's metal. You know, once the case is over, they wipe it down with the wipes that we have available, and it's extremely easy to clean versus a big anesthesia cart. So, and then the next step will be PPE logistics. So for us, it's head cover, gloves, gowns, face cover, and eye cover. Obviously, depending on where you are, this might have some kind of variation. And for this to happen, sorry, we need to have a donning and doffing station. So this is areas where you put on your PPE and then you take off your PPE. There are many studies that show that doffing is very important. Donning is important. Obviously, you want to protect yourself, make sure you have the right equipment. Doffing, especially after a big procedure like an aerosol producing procedure, is particularly important because you have particles on you and you have to make sure you decontaminate yourself in a very safe manner. So for that to happen, you need to have designated areas. So you need to have an area and a station that's only for donning, and then you have to have an area or station only for doffing. So the way we did it is our donning area is a clean area and it's close to the other clean areas. It doesn't make sense to have your donning area next to a room where all the soiled utility or the decontamination of the ORs go to, right? It doesn't make sense. So our donning area ended up being, I have a picture in our anesthesia tech room. So it was a corner in the tech and the supply room that we labeled and have pictures for donning and doffing. I highly recommend that you have a picture for providers who don. It's very easy to forget something when you're donning, and you forget something, you contaminate yourself and other stuff. So have a clear layout of what the steps are. Usually when we don, we have someone else watching us or helping us don, in terms of, if we're wearing a PAPR, someone is there to help us through the steps of the PAPR and how to check it. In terms of wearing the gown, same thing, and the gloves. And at the end, we do a final inspection to make sure everything looks good, and then we go into the operating room. The doffing area is the same thing. So the doffing area, we have two doffing areas. So the first doffing area is the staged process. Our first doffing area is the operating room. So you take off your gown and your gloves in the operating room, in the trash can, you sanitize, and then you leave the room and you take off your PAPR that we clean in a different doffing area. This might not be very relevant for you guys, but just so you know and you have an idea. So this is our clean area. It's in the middle of the anesthesia tech room. We put all of our stuff that like cell phones, like stethoscopes, things that you don't need to bring in the OR. We have disposable stethoscopes in the OR. If you need to bring your own, then have a plan on how you're going to clean your stethoscope afterwards, right? So we put here our badges, all that stuff goes in there. And then gloves, gowns, and then up here is hiding, because we're hiding all of our N95. So our N95 are hiding under here. So they're under. So this is our donning area. And then our doffing area is where we take off our PAPR and clean it. So we have a dedicated trash can. We have the hydrogen peroxide wipes. That's what we use. And then gloves to clean the used PAPR. So PPE logistics for LMIC consideration. Obviously, there's a shortage of PPE, not only in LMIC, but also in high-income countries. As you can tell in the news, everyone is in very high need of PPE. So basically understand your available PPE and your limitations. So if you only have one PPE, then that means only one provider goes in and does the intubation, right? So it's understanding the process of your hospital in your current setting. So I would say and highly encourage you to really understand the plan, the future plan for PPE for your hospital. Are you going to use for like gowns? Are you going to use the cloth gowns that you're going to wash and sterilize afterwards? Are you going to use plastic over your mask? A lot of places now have started to just put plastic over their masks. And then how you're going to use that. Have a plan, whatever plan it is, try to make it evidence-based by looking at other hospitals who's done it before and their limitations, but have a plan in terms of understanding your current PPE situation and its limitations. If you're recycling or decontaminating PPEs, again, have a well-established process and workflow, especially with decontaminating. Our hospital now just started decontaminating N95s. So now we have a process. We put our N95s in a brown bag, and then the brown bag we put on our waist with a clip, and we use it all day. Pretty much when we have cases, between cases, you use it. And at the end of the day, you put the N95 in the bag and it gets sterilized under UV light. This is new for us. I think it started like maybe 4 days ago. So understand the process, and then establish workflow that would adequately protect high-risk healthcare workers. It's very important. You really have to know where your PPE is going. You can't, you have to know how to allocate your PPE. So anesthesia providers, emergency room providers are very much high risk to be exposed, because the emergency providers are first lines. They're the ones who see the patients first, and they can be exposed without even knowing, because you don't know if the patient is positive or not. Anesthesia providers, or any providers, ICU providers who are doing aerosol generating procedures, are much higher risk, as I said earlier, than a physician who's seeing a patient on the ward. I'm not saying that they shouldn't get a PPE, everyone should, but understand who's at a higher risk and protect those at a much higher level as well. Again, clearly label donning and doffing area, decide as a department and as a team where your donning area should be, where your doffing area should be, have a well worked out plan, and then educate the rest of the staff and the department. Everyone should know. So when we did our setup, we had to educate everyone. You know, we had to educate our department, our nurse anesthetist, our anesthesiologist, and then the nursing staff in the OR. I mean, it's constant education, you know, because the information is changing every day. Hospital policies are changing every day. So it's a constant wave of education. It's not like a new disease came and we have the treatment and this is what we're going to do from now on. It's constantly changing based on evidence, based on many different things. So you have to be ready to be constantly educating and having patience to do that as well. And then lastly, make sure, again, you educate your staff on proper donning and doffing, especially doffing. When we doff for us, we do two provider doffing because we want to make sure someone else is watching. Some of us have done it so many times now that it just becomes very easy for us to do it on our own, and we feel safe enough that we're doing it without contaminating ourselves and other stuff. But you should have a system set up, at least at the beginning, where you're educating your staff well, you're educating your residents well, you're showing them proper donning and doffing, and making sure, you know, you have a well thought out system. Yeah, and then just to add on this, you know, I'm also part of I'm the co-lead for the COVID acute response team, where we go and we get called for intubation around the hospital. So our team would go and intubate patients who are COVID positive or PUIs. And even for that, it's a different topic from this, but even for that, we had a very well worked workflow system. If you intubate a patient, so we expect that provider to go change their scrubs, you know, things like that. Or some people will shower afterwards. So just have a system set up so that you're not really forcing staff to do something, but you're also making sure they're not being exposed to the virus. So our workflow, so that was kind of the setup. And then our workflow included anesthesia, surgery, or in PACU nursing, and some of the ICU staff as well. So, you know, as you know, like implementing a new policy is extremely hard. Even in these times where people are open to hearing and receptive, it's not easy. So this requires a very, very strong coordination between different disciplines. So surgeons have to be on board, anesthesiologists and anesthesia staff has to be on board, operating room nursing staff and leadership has to be on board, recovery nurses have to be on board. To some level, the ICU has to be on board too, because we get patients from the ICU. So we had to modify our workflow on how, when we get a patient who's COVID positive, who's intubated from the ICU, what should be our workflow, you know? We had respiratory therapists also involved. So it's not just an anesthesia job. This is a whole multidisciplinary job. And this is something you should know as you're moving forward and as you're getting stakeholders to participate. So there's a lot of writing on this. Don't worry, we are not gonna go over all of this, but this is how our workflow started. So we divided into different steps. So we had a step before the patient arrives into the operating room. On the right side, this is a checklist that we made for our anesthesia techs. So it's a lot on here. I'm not going to go over it, but basically make a checklist for your anesthesia techs, whoever is setting up the room, or your residents, or whoever is helping set up the room. So for us, we wanted to make sure, the main thing is once the patient comes to the OR, we don't want to open the door 10 times, right? You want to bring the patient and hopefully close the door and not have staff come in and out, especially if your room is positive pressure. For us, because you know that especially after intubation, extubation. So we have a policy that I'm going to go through later based on what we saw from the CDC document earlier. We wait 15 minutes after intubation and extubation before anyone comes in. So even then, in between cases, we really try to avoid unnecessary stuff coming into the OR. So our plan is set up the OR how you want it, so you minimize the amount of traffic that comes in afterwards, and they're not random people walking in and out. So the checklist on the right side, it's for the anesthesia techs, and it's telling them the things that they should be checking to make sure there's a blood pressure cuff, there's a bear hug, there's this and this. So this is a checklist. They're asking the anesthesia providers, do you need these things in your room? Do you need them now? If you don't need them, then I'm not going to bring them. The one at the bottom is things that we need in the OR regardless of cases that are going on. So covering the ventilator, a bucket with the trash bag for our airway to double seal it, like a regular trash can, a bear hug. I mean, this is very detailed. The HEPA filters, inline suction, and then on the Mayo stands, the Ziploc with the emergency airways. So we put everything for them, so it's easy to just go and check it off, and they don't have to think about it too much. So before the patient arrives, you need to have some kind of a checklist available to make sure all you need is there. And then we told the anesthesia providers to gather all necessary equipment, drugs, airway adjuncts before the patient arrives. If you need something and you think you're going to need it, just get it now and have it in the room ready to use. Because the last thing you want is calling someone after intubation, hey, I need something and I need to send that from the OR. Just have everything ready. And then we also communicated with the OR nursing to gather their equipment and have everything ready in a timely manner. They open everything, and then once they open, they cover it with a drape during intubation and extubation, and to minimize contamination. Again, as I said, the goal is to minimize the OR door opening and closing during the case. And then at the end, I put on here, we assigned an OR runner. So in case you need something, we assign someone who's going to be at the door with the PPE to give you stuff and hand you stuff if needed. So we had an assigned runner at all times for these cases. And then before the patient arrives, we do a team huddle. Usually our team huddles happen with the patient at the bedside in pre-op, but obviously with this, it's not possible because the patient is on the ward or in the ICU, and they come directly straight to the OR. So these patients don't go to pre-op, they don't go to PACU. It's to limit contamination, obviously. So if they're ICU patients, they come from the ICU straight to the OR. If they're a ward patient, they come from the ward straight to the OR. So we do our team huddle before they get there. We do our usual OR huddle plus COVID specific huddle. So some of the things that we do is, first is we identify the patient transporting providers. Anesthesia transport these patients. So we go and get the patients. So when we go and get the patients, we're in PPE. So because we're gonna need to be in PPE anyway. So we're in PPE. We designate who we're gonna be transporting, and we make sure that is clear during the huddle. We review the patient transporting consideration. So are we wearing PPE? What are we doing? If it's an ICU patient, we decide how many people we need. Sometimes we need 3 people because the ICU patients are complicated to transport. We figure out which elevator we're going to take, which route we're going to take. And then we identify intubating providers. So we say during the huddle, these 2 providers are going to be in the OR intubating. And then we review the PPE plan for all anesthesia providers in the room. So we decide this is a high-risk patient or this is a COVID positive patient. We're going to intubate with an N95. In case there's a disconnection of the circuit, I think everyone else should have an N95. So we discussed that with the team. And at this point, we have a really well thought out plan in terms of how the surgeons should be protected, which is a different topic. I'm not going to go over this. And then we also discuss extubation and recovery plan. So this is, with the huddle, this is just for you guys to see. This is a anesthesia provider checklist. So we made this for anesthesia providers so they don't forget and they know what to bring into the OR. So on here, we have induction agent. We usually tell them, we use propofol. So we usually tell them 2 sticks of propofol, so 400 milligram, just in case you need to give more and you don't have to open the door. Narcotics and benzodiazepines, lidocaine, succinylcholine, rocuronium, antibiotics, antiemetics. Usually we give 2 antiemetics, so bring them Sugamadex, saline flushes, and then at the bottom we have equipment and line monitoring. So if you need extra monitoring for your patients, bring that in beforehand. So this is just a reminder for our text. And then we have drug boxes. So at the bottom, we tell them to clean the drug boxes before they return it to pharmacy. These are just ideas for you and cues on how you can streamline your process. And then from this on, patient pickup and transport. So as I said earlier, we go and pick up the patients from the ward or the ICU in full PPE. Our hospital policy is when we go to the room is that we wipe down the patient rails. So the bed handles, we wipe them with a decontaminant, and then we make sure the patient wears a regular mask, and then we put a clean sheet over the patient so that just in case someone else bumps into the bed or touches the rail, the handles are clean, the patient is covered with a clean blanket, so there's less contact. Even if other people in the elevator accidentally touches the patient, there's no contact. And then we assign a clean person to interact with the environment. So usually when we transport a patient, if it's a ward patient, it's an anesthesia provider, and then depending on how easy the bed is to manage, sometimes it's two anesthesia providers, but usually it's one anesthesia provider, and then we have the OR nurse that goes with us, and that nurse is usually responsible to interact with the environment. So they open doors, they're clean, they haven't touched the patient, and they don't have to be in full PPE. So they open the door, they touch the elevator, and they do that kind of stuff. So have that kind of set up as well. And then again, we talked about donning and doffing. So when the patient comes, you do your donning in the donning area and your doffing. We already talked about this. And then for induction intubation, so you've already done your huddle. Everyone on the team knows. We had a problem when we first started this, the surgeons not showing up on time. It was kind of a big issue. So sometimes, we intubate, and then suddenly before the 15 minutes, a surgery resident will walk into the room, and it was it was against everything we worked for. So we had a very deep conversation with the surgery team, and we told them, everyone who comes to the OR for this case needs to be present during the huddle. So if you're not present during the huddle, you technically cannot come into the OR. So we made sure every resident or surgeons who are going to be part of this case are present during the huddle, so they understand our setup and the system. So that was one thing that took a little bit of time to get in motion. But anyway, so now for induction and intubation, we have the designated intubating provider and helper. So usually we have two anesthesia providers. The most experienced personnel should intubate. We avoid trainees for this. We have trainees in the OR to push medications and drugs, but for patients who are COVID positive or PUIs, we just avoid them dealing with the airway. I think this is not a good learning opportunity for them. There's extremely high risk of contaminating themselves. There's extremely high risk of the patient not doing well. These, when we intubate COVID positive patients, they have very low reserve. They desaturate extremely quickly. Like, I don't know how to explain it. Like, it's more than a pregnant patient. Usually pregnant patients, when you do general anesthesia, they desaturate extremely quickly, but they're worse than that. So if you have trouble with the airway, you can be in a very, very precarious situation. So for our department, we have agreed to completely avoid resident trainees to intubate, or nurse anesthesia students to intubate. So that's already in our system. Both providers should be in full PPE in the OR, and all other staff should leave the OR for 15 minutes after intubation. As we talked about, based on the amount of airway exchanges in the OR, we decided as a department 15 minutes is a good amount to wait. We went from 20 minutes to 15 minutes after much discussion. And then, so that's part. And then we pre-oxygenate the patients for 5 minutes at 100% oxygen. By the way, this is all from the anesthesia patient safety site. And then we perform a rapid sequence intubation for all patients. Obviously, for obvious reasons, you don't want to aerosolize anything. You just basically want to minimize any of the air in the trachea to come out to the environment. So avoid bagging the patient unless you absolutely have to. Have I done it before? Yes, I have bagged a COVID patient because we had a difficult airway. And if you have to bag, you have to bag, But obviously that shouldn't be your first go-to step. use a video laryngoscope if possible, you know, because with the DL, you're so close to the airway versus a video laryngoscope where you're far away if you can. This is only obviously if you can. And then once you're done with the laryngoscope, we do a double glove technique again, as we talked about. You intubate, the tube is in. As soon as the tube is in, you take off your outer glove and you put the blade into your outer glove. You discard that into the container that you have and seal the container. And then right afterwards, you connect the ET tube and inflate the cuff. Your helper at that point is clean. Your helper should interact with the ventilator and put the vent settings and things like that. We try to make the helper as handoff as possible from the airway to limit contamination. Obviously, if it's a difficult airway, then you know both providers are doing the airway as well. And then so let's see. So yeah, seal all used airway equipments in double Ziploc bags, and then have them sent to decontamination disinfection. Every circuit for us have a HEPA filter and inline suction. We're very fortunate to have that. This is not only for COVID patients for us now, we have it for every patient because now there's so many asymptomatic carriers who come to the OR and there's a high risk of with us of generating aerosols. So that's in our system now. And then we avoid circuit disconnection at all costs. Obviously, you know, don't disconnect the circuit and change your outer gloves before interacting with the ventilator. So it's a lot of changing your gloves, a lot of making sure having a mental note of what you're touching and making sure you're, you know, being as minimalistic as you can with how much you interact with your environment. So this is just a quick example, just so you guys have an idea. This is our filter, and then we have the inline suction here on the left side. This is another way where we put in our filter as well. And then this is our second filters on the machine. We have an inspiratory and expiratory filters. And then here we can also use, we use the mannitol filters that we give for drugs. These are also somewhat effective at filtering some particles. Epidural, I don't know if you have epidurals, but I doubt you have it. But anyways, the epidural kits, they have filters in them that we don't really use for our epidural. So these are actually pretty effective at filtering a lot of the small micron particles. And then this is our CO2 monitoring. When we have patients from the ICU who come to the OR, we don't want to disconnect their AT tube into our ventilator. So we hook it up. We basically bring their ventilator. The patient stays on the ICU ventilator during the OR case, and we use their micro stream. That's what it's called. This is a micro stream where we check the CO2, so we don't contaminate we don't disconnect our circuit. And then for maintenance phase, again, avoid circuit disconnection at all costs. If you have to disconnect the circuit for any reason, make sure you have appropriate PPE when you do that. And then make sure you tell the rest of the staff. If the rest of the surgeons and OR nursing don't have appropriate PPE and they're doing a case, you have to disconnect the circuit. You have to let them know so they can step away, right? Or leave the OR when you're disconnecting. So you have to be very careful when you're doing this. If you have to disconnect the circuit and you don't have a filter, then you can clamp the ET tube if urgent needs to disconnect. So just clamp the tube. Sometimes after intubation, I intubate and I put my finger over the tube just to avoid anything from going in and out. And then we connect it and then I change my glove. So just have some kind of a system, either clamp the tube, put your finger on it or something, you know. If you have to suction and the ET tube, then you let everyone know so they're protected. Again, avoid open circuit suctioning. We have an inline suctioning. I don't know if you guys have that, but if you don't, you can maybe design one where you can have the suction that's already inline. You can put the suction in a plastic bag and make sure that whole thing is a contained system. So you can be creative and come up with different ideas. Avoid coughing. Obviously, the patient, you don't want them to cough. So light anesthesia is not your best friend. You want them to be in deep anesthesia, and obviously you want to paralyze the patient as well so they're not moving and coughing. Extubation is a very high contamination phase. Obviously, more than intubation, if you have to protect yourself more than intubation, I would say extubation is the right time, because you're removing the ET tube, and it's a very disturbed environment where the ET tube is flying everywhere, the secretion everywhere, the droplets everywhere. So during extubation, you have to really have it planned out in a very thoughtful way. So first of all, when the case is done, transfer the patient to the bed without disconnecting the circuit. That's what we do. So the case is done. Usually what we do, we extubate, we put the mask on, we transfer the patient to the bed, we all leave. So now we decided we're gonna keep the patient intubated, keep the circuit connected, and then transfer the patient from the OR into their bed, their hospital bed, so that it's one less step for you to do afterwards. And then once you've done that and you're ready for extubation, you let the staff know and you say, hey, I'm going to extubate. Everyone needs to leave the room. Everyone leaves the room except for you. And if you feel like you need another provider, make sure they come in full PPE, right? Minimize coughing. So usually I have them spontaneously breathing on the ventilator and kind of ready to be extubated. It's very useful to use a plastic barrier over the patient face while removing the ET tube. So more than intubation, we have a few faculty in our department who designed intubation. I wish I had the picture. I don't have the picture, unfortunately, but they designed just like polyester, like rectangles, like a little area where we can cover the patient. So, and then they put a plastic drape over it. It's very easy. It's basically like a polyester device, very easy to make, and then they put a plastic drape over it. And for intubation, I don't find those easy to use for intubation. It's very cumbersome, but for extubation, where you're removing the tube, you just put that over the patient. It's a plastic cover and it contains the aerosols in that area, and you can easily and safely doff it, you know. And so I think it's very important. It's like worth thinking about having a plastic barrier over the patient's face while you're removing an ET tube. Once the ET tube is removed, we immediately place the ET tube into a sealed bag and dispose it so it's not out in the air. And then we also immediately place a face mask on the patient after the removal. We change our gloves after extubation and sanitize. And then depending on the scenario, if it's an ICU patient, then we go straight to the ICU. If it's a patient who needs to be recovered, these patients recover in the OR. You don't want to take them to PACU. None of these patients go to PACU or recovery area. So they recover in the OR. For us, what we do is we recover for 15 minutes because that's how long we have to wait anyways until anyone else comes into the room and all the microbes are exchanged. And after 15 minutes, if the patient needs longer recovery, the recovery nurse comes from PACU and recovers the patient in the operating room in full PPE. And then you take the patient to the ward when they're ready. This is a study that shows quickly, the spread of this dye they used during extubation. So it's a mannequin, they used it on a mannequin, and they made the mannequin cough during extubation. So they put the dye in their trachea and their lungs, and they made the mannequin cough. And then this is what you can see. So, I mean, it's going everywhere. You can think of it as like the virus, right? The virus is going everywhere. And so they put a drape here just to show how much of putting a plastic drape over an area can really minimize the amount of contamination. So compare A and C. So this is just for us to show draping is effective. The draping is a good way of minimizing contamination. They also had a drape under the patient here, but I think the idea is to put it under and then remove it afterwards to not contaminate the bed under. But you can really tell, like even the face of the patient is contaminated. We can't decontaminate the face of the patient, unfortunately, but it's for you to understand, you know, touching the patient's face, eyes, any mucosal membrane is high risk, and you have to change your gloves in between and avoid that kind of interaction. Okay, so for LMIC consideration for induction, intubation, maintenance, and extubation, if you have HEPA filters, it's great. If you don't have it, use an ET2 clamp when you're disconnecting the circuit. If you don't have HEPA filters and you if you if you have a COVID positive patients and you're using a ventilator and you can't protect your ventilator, then assume that ventilator is dirty or unclean and contaminated at that point, and use that one ventilator for all patients. That's why it's so important to have a dedicated OR where the ventilator stays there, your ET tubes stay there, and it's only used on those patients because you don't have any other way of making sure it's not contaminated. Again, same thing, use dedicated ventilator for all COVID positive PUI patients. And then again, here is discuss, is decide on the time frame from when you want the staff to come back into the OR. So I understand a lot of your operating rooms don't have air exchanges per hour, and maybe not set up, but you need to kind of discuss as a team, what is the best time, what is the best way to, or how long should we wait until intubation or extubation to let providers come in. We had a few discussion with infection control, and what they were telling us, basically they were saying they were saying basically the aerosols and the droplets need time to settle on the surfaces, which makes it easier to clean, and they wanted us to kind of wait that time frame for that reason. Our reason for waiting 15-20 minutes is because we wanted to make sure the aerosolized particles were taken out of the OR to the ventilation system. So there's a lot of discussion about that. I don't think there's a right answer. I don't think anyone fully understands exactly how these viruses move, get aerosolized, are transmitted, honestly. So I think it's a discussion to have with your department. And then again, transport out of the OR, same thing as transporting into the OR. We clean the bed rails with the contaminant. We change our gloves. We put a clean U sheet over the patient's body, and then we make sure the patient wears a mask. And then again, as I said earlier, these patients should not go to PACU where there's a high traffic and recovery in a recovery area where there's a high chance of them being contaminated. If they go back to their ward, they should have their own room. Or if they don't have their own room, then they should be in an area that's a COVID positive, a PUI area, so that your contamination risk is low and your risk of spreading it to other patients is low, or other staff too. And then in terms of OR decontamination, I'm almost done. I know I'm kind of running out of time. You wait, so we wait 15 minutes before allowing the staff to come into the OR, as we said, unless they're wearing full PPE. But a lot of our cleaning staff crew are not wearing PPE, and we don't want to waste it using it on them if it's not necessary. So we have them wait 15 minutes. And then this is from the CDC websites. These are some of the disinfectants that can be used. Obviously, there's so many different things you can use. There's hydrogen peroxide, and from different companies, there's sodium hypochlorite, phenolic. I mean, there's so much stuff. So the stuff that we use is hydrogen peroxide to disinfect. We use the wipes to disinfect our workstations, and this is the contact time in minutes. So it just needs to be in contact for 1 minute to kill the bacteria. And some of these take 10 minutes, some take 30 minutes. So really depending on what you use with your hospital policy and infection control, yeah, you have to decide what to use, what's used to be what's used to clean these ORs and things like that. And I think as anesthesiologists and even overall people working in the OR, this is a very much teamwork effort. So this is not just an anesthesia problem. This is a surgery problem. This is a perioperative nursing problem. It's an infection control problem. It's a perioperative leadership and hospital policy on a higher level problem. So I think it's to your best interest to understand your current system, understand how things are done. How is our operating room being cleaned? What do we use to clean it? Is it effective now? Should we change something? So it requires a lot of questioning and a lot of inquisitive minds and a lot of collaboration. So I think this is, I don't know if you have a COVID OR, a workflow system set up already in your hospital. If you don't have one, I think you need one regardless. The numbers are increasing, and even, in months, I think we're going to have patients who are going to come to the operating room that need procedures. Our case load for COVID positive patients is not as high because those patients rarely come to the OR and require procedures unless it's a trauma patient. So a lot of our trauma patients are basically treated as suspected PUI. So we think of them as possibly having COVID. So they sometimes have to come to the OR for procedures. A lot of the patients that come to our OR setup are patients under investigation. So patients you're not sure about, right? So these patients, you treat them like they're COVID positive. So you're gonna have that in your hospital, that's for certain. So you have to come up with a system that's going to be safe for your patients, that's going to be effective and efficient, and that's going to minimize the amount of contamination to your staff, to other patients, you know, and to your family members when you go home. So it's to your best interest to work together and figure out a system that kind of works for everyone. So I'm done. So this is just want to say special thank you to my team mates who are on this team, on this project. My colleague is Dr. Arun Prakash, that's him right here. This is him. He's very, very inquisitive, and he was trying to figure out a system to, you know, he was saying, oh, what if we run out of PPE? Maybe we can use a mask and a filter. I mean, obviously this can probably work as an N95. This is essentially an N95. And then my other, she's the lead for the OB obstetrics anesthesia side of setting up a COVID OR. And then this is us here working and figuring out and labeling the system as we're working together. So I just want to thank my teammates and then the San Francisco General Hospital anesthesia department as well. So I hope I didn't keep you guys too late. I can take questions now or any comments if you guys are still here.
Thank you so much, Dr. Betty.
Yeah.
That was just a great presentation and very much informative for us working in low-income country, Ethiopia. So until some of our viewers participate, I have a couple of questions for you. Are you able to hear me?
Yeah, I can hear you.
So the suctioning technique that you use, you have already mentioned it. We don't have the inline type of suctioning for such patient, COVID positive patients or any other patients. So the only option of minimizing aerosolization would be to clamp it, right? Or is there any other technique that we can use? Maybe suctioning through the intubating plastic bags or something like that. What do you recommend in our setup?
Yeah, so let me go back to let's see if I can find the slide. So our inline suction, this is a good one. So as you can see, the inline suction is here, right? It's going inside the ET tube, right? So we don't use it much. It's very rare that we use the inline suction because it's going inside the ET tube. The only time you use the inline suction is if the patient, you have like mucus or secretion inside the ET tube, right? If you do have that, then we use the inline suction, which is useful. We do use the suction outside. So, you know, before we extubate, like, you know, like everywhere, as you know, we suction the oropharynx to make sure there's no secretion after we extubate and there's no laryngospasm and things like that. We still use the external suction, to be honest, and it's right here. I don't know if you see it. We have the external Yankauer, but the main thing is if you do use the external suction, first of all, we don't use it when the staff is in the OR. So we use it for intubation or extubation. So unlike before, like other times where you just decide to suction the patient, we don't do that until everyone else leaves the room, first of all, when you're fully protected. After you use your external suction, like you're suctioning the oropharynx, we put it into the same, we have a little container, put it back in there to make sure it's not spreading to the environment. That's one thing. If you decide to do suction the ET tube, right? If you have to suction and you don't have an inline suction, I suggest that you disconnect the tube. First, we clamp the tube, and then disconnect. And then after you disconnect, make sure your ventilator is paused so that the ventilator is not breathing or like expiring any of the air into the environment. And then once it's clamped, you put your inline suction quickly, suction and come out and reconnect. there's really no better way of doing that. You can do it under a plastic drape to make sure it's contained, and you put your hands under the plastic drape and just make sure it's contained within that environment. You can try to design a way where you put the inline suction. You guys can be creative and design it to make sure you have you put a plastic drape over the inline suction and have it kind of hooked to the mask. So I think this is where you have to be a little bit creative in how you do things. But I think clamping the ET tube is a good way to go about not making sure nothing gets exhaled.
Okay, thank you, Dr. Beatty. Maybe I can continue with some of the questions. The fact that we don't have negative pressure rooms, does it mean that we need a more strict PPE recommendation in low-income countries? The fact that we don't have HEPA filters, even more strict recommendation for PPE for healthcare workers taking care of COVID positive patients?
Yeah, that's a good question. So as I said again, our ORs are not negative pressure. Our OR is positive pressure room. So that's one thing. The only difference I think between our OR and your OR is that we have the air exchange per hour. So at least our air is exchanged for us is about 35 times per hour. So 35 to 40 times an hour. So there is a constant flow of air, and air is being exchanged, and based on the CDC website, that eliminates the amount of aerosol and microbes that are in the air. And this is for all ORs. In terms of PPE, I don't think there's any additional PPE that you can get really. And what kind of PPE are you talking about, right? If you have an N95 and a gown and a mask, I think that's kind of like, and an eye shield, that's kind of like all the PPE you need. I think it's important to know how you're recycling your PPE, right? And how you're decontaminating your PPE. I think that's kind of another bigger project. But I think at this time, you really have to figure out how your ventilation system is working, or if you have any ventilation system in your operating room, and then go from there.
So the PPE recommendation I was talking about was in terms of timing. For example, you said 20 minutes after aerosol generating procedures, or for example, to go to the ICU where we don't have many of the filters, or the rooms are shared among patients. Would we need more PPE recommendation in terms of wearing what in what kind of procedures and environment? That's what I meant actually, but you made it clear.
Yeah, I mean, I think if I understand correctly, you're saying during intubation and extubation, do we need extra PPE because of the OR not being negative pressure?
Mm-hmm.
Yeah,
and
I mean,
and taking care of COVID, for example, transferring patients to the ICU, or taking them to the ICU, or intubating them in the ICU as part of the response team, for example.
Yeah, so I think if you're intubating a patient in the ICU, that's a different story. The patient should have their own room or isolated area. So maybe if you don't have that, so what you can do is, if your ICU is a big ward with like 10 patients beds next to each other, what you can do is you can create an isolation area so the way we do it here is we just put plastic, like this big thick plastic, and we cover one side of the hallway and create a room. So you can actually create a room that's isolated in your ICU, create an area where if any patient needs to be intubated, they come into that room, get intubated in full PPE. So the providers are in full PPE, the anesthesia providers, and then you can wait a certain amount of time. I'm not sure what the right time frame is to wait, but that's something you have to discuss with the rest of the department until the aerosols are settled, and then move them into the general population per se, or like the rest of the other COVID patients. Your COVID patients should really be isolated in terms of wards. You know, I understand like the ICUs, you don't have a lot of ICU beds, but even within the ICU, you should have COVID positive or PUI area and like non-positive or negative patients, just to minimize the amount of contamination you're having. you should also have like staff, like the staff available should be like nursing staff, for instance. They should be kind of assigned in one area and have a system where they rotate. So here in our hospital, there are COVID nurses, ICU nurses, and that's kind of like that whole floor is a COVID ICU, and so the nurses only work on that floor. So those nurses don't go and work on non-COVID floor, just to minimize the amount of contact, and you can have a way where you can rotate them and have them work for a week. They're off for a week and a half, monitor themselves, and have another batch of nurses that come on. So I think the ICU needs a different kind of flow as well, and a setup to make sure your contamination level is low. But I think a quick way to create an area is just creating an area within the ICU where all the intubations happen. Instead of intubating the patient in their bed where they're next to other patients, you can take them, move them a few meters away into an area where you think is the safest area to intubate, and have it isolated with plastic, or like close it off, have a system available so you can just intubate in that area, and that area is the contaminated area that everyone knows. So when you're in there, you have full PPE on. Regardless, when you could take care of these patients, you need full PPE anyways. But for us, we use the N95 and the PAPR for intubations. And that should be enough. N95 should be enough for intubations based on the CDC website and the ASA too. So even when we get trauma patients and we don't know their status, you get a trauma, they come in from the ED straight to the operating room. We have no idea if they're COVID positive or not. So we treat them as if they are a PUI. They're a patient under investigation. So we wear N95s when we intubate them. So in fact, now we're using N95s to intubate all patients. It doesn't matter if you're asymptomatic or not. This is our new policy now. And we're starting to test people who are asymptomatic. Any patient who come to the OR for cases now have to get tested. This is a new policy as of 2 days ago, So I think as we're testing, you can get more answers and your flow can be more streamlined.
Okay. One more question, Dr. Beatty, for me. How is the entire anesthesia team duty program organized? Like, is there a tire program? How do you minimize exposure versus, burnout? How do you balance it? Is there
Yeah. You mean the intern, or you mean like all the anesthesia stuff?
The anesthesia stuff.
Yeah.
Is there a specific team by team or a rotation or anything?
Yeah, that's a really good question. So, fortunately, so the way our hospital is organized is they had different conditions. I think this is also important to have. So our hospital have different condition levels. So condition brown, I think it's maroon, is when it's considered, we have, I think, over 70 intubated patients. We have no ventilator, and we are completely outresourced. That's condition maroon. And then right now, I think condition green is when you don't have, you still have over, I think 75% of your ventilators available. There's no staff shortage and things like that. And then there are different conditions between green and maroon. So right now we're in condition yellow, which means, I forgot the exact number, but it basically means we have at least over 50% of your ventilators available for patients. There's a low amount of intubated patients. The surge is not that high. And then we were condition orange 2 weeks ago because we had a little more of intubated patients. So I think having a system where everyone knows what condition the hospital is in. So we get emails every day. It's called the Daily Digest email, where the hospital staff communicates with us in terms of what condition we're in. So they're like, oh, we're in condition yellow today. We have this many intubated patients, COVID patients. We have this many non-intubated COVID patients. We had this many discharges and deaths. So we know, everyone understands your condition level. So each department can adjust accordingly. For anesthesia, based on the condition of the hospital, we deploy our resources accordingly. So when we were condition orange, after orange is red, and after red is maroon. So when we're condition orange, we decided to, this is obviously something that was worked out with the department and the rest of the hospital team. We decided to use anesthesia to help the rest of the department and the ICUs. So our anesthesia staff was willing and, or I guess, asked to go and help in the ICUs, and also we were asked to have an anesthesia response team. So the team came up because we are called for intubations in the hospital, and we're getting called on a regular basis. And usually we have a team that goes and intubates, but the team also handles trauma. So we decided to make sure we have a separate team that just does COVID intubations, because we also thought the number is going to get really high and our demand is going to be high. So we organized the COVID acute response team. It was and one anesthesiologist, one CRNA together. They just go and intubate patients. Every time there's an intubation for COVID positive or a patient under investigation, they get deployed. So I think having a team that's just focused on a task like that is amazing. So in that team, we had, I think, it's a voluntary team. So we had 10 to 13 anesthesia providers who volunteered. And then we had 6 to 8 CRNAs, nurse anesthetists. So between us, we were able to rotate. And so our primary goal and role at that point was to be part of the DX team. So our setup was to have one team on for 4 days. So we'll do 4 days, 3 to 4 days on. So Monday, let's say Monday, Tuesday, Wednesday, Friday, and then we'll be off for almost 7 days, so that if you are exposed, you're able to monitor yourself at home. So that team can go home, and another team will do it for 4 days, and another team will do it for 4 days. So that was kind of our setup for the acute response team. And then the rest of the team, of the anesthesia team, they do the normal cases in the OR. So everyone else does any of the rest of the remaining cases. If you get a COVID positive or PUI patient into the OR, anyone should be able to do those cases based on the new workflow. So part of our job was to educate the team, the rest of the anesthesia type stuff. So I think in terms of burnout, is having teams that are focused on one task. You know what I mean? So it's really good to have designated teams or point people. So with the acute response team, we would, like me and another provider, with the co-leaders, but then we also had 2 people under us who also were contact people. So when people had questions and needed help in the OR for COVID patients, they would contact us and we can go help them. So having a system where you have teams available for specific tasks, it doesn't overwhelm the rest of the staff. Having constant education, I think initially part of the frustration for us is not understanding the flow. Like we were, when this whole thing was happening, end of February, we were still doing elective cases. We were still getting no training. And so everyone was very frustrated in terms of what are we doing to make sure we're safe? What kind of workflow are we doing? And as we started doing them, I think the staff felt prepared. So I think not being prepared can really bring down the morale of the team and the staff. So what you can do is prepare your staff and prepare people who are working with you. And the way you can prepare is by doing it yourself. No one is going to come and do it, right? This is your department, this is your team, this is your hospital, these are your patients. You're going to expose yourself. So you really have to everyone has to take the initiative. So when a team of people come up with a plan and workflow, everyone else is on board and everyone is trying to help, is trying to make the system work for them instead of dividing and not having a conducive environment. So I think especially in a crisis like this is why I have this PowerPoint, and it requires a lot of teamwork, multidisciplinary teamwork. So we work with the ICU very closely now. We work with the surgeons closely before, even closely now, and so when we cancel a case because the patient is not an urgent case and the patient COVID status is unknown, the surgeons are understanding. Because they understand the workflow. They've been educated, so they are not upset that something is not happening. They understand this because of infection control and contamination. So I think having stakeholders from each department and educating the rest of the department is really important to avoid burnout. And then In terms of trainees here, well, we have residents and interns and things like that. They're still involved in COVID cases, and we still have to think of them as essential workers. They are needed in the hospital. They can't just not be involved despite not having full training. So you have to think of them also as a potential burnout. So, and also with their training, they might not have enough teaching happening. So we had a lot of problems because our residents are getting deployed everywhere. They're going to the ICU, they're doing cases. Some of them are staying home and being quarantined. So there was a lot of frustration in terms of like, we're not getting any teaching, we're not learning anything. It's hard. It's just the way it is. That's the way it is. It's hard to teach residents at this time, but I think it's easy to teach them COVID-related workflow issues. So they're also aware and they're also protected. So that's what I would say about that.
Thank you so much, Dr. Beatty. That was extremely informative. But just maybe one last question, if possible.
Yeah, no problem.
When you after you're done with surgery in the OR, who transports this patient to the ICU, for example? Another team or the same team transports them? And would they you said they would need full PPE, right? So would they transport them wearing the same PPE they wore it in the OR, or a separate one?
That's a very good question. So this was a lot of discussion with the infection control that we had. So let's take the scenario of transporting a patient who's not intubated, not ICU patient, to the ward. So you wear PPE, you extubate the patient recovers in the OR. So first of all, you wait for us it's 15 minutes. So we wait 15 minutes and before even leaving the room or anyone coming into the room. And so you extubate, patient is stable. Now you want to go to the ward. When you go to the ward, this is kind of like the gray area or fine line. If the patient is stable, you're not gonna touch the patient. You're not gonna rescue the airway. You think they're like completely fine. There's no intervention that needs to be needed. You can take off your PPE in the OR, change your gloves, still keep your N95, but clean the rails of the bed, and the anesthesia team transports the PPE to the ward. So at that point, you don't have to wear full PPE when you're transporting from the OR to the ward. Because this is based on our infection control team of hospital team. The patient has a clean drape over their body. The rails are wiped and clean. They wear a mask. You wear a mask and you have gloves on. That's all you need to transport them. For ICU patients, it's different because ICU patients require constant care. So you're touching them, you're making sure things are not moving, you're giving medication. So with the ICU patients, we wear full PPE. So for ICU patients, you don't extubate. So they're usually, well, if you extubate, but usually they remain intubated and go to the ICU. So we wear the same gown, we wear the same mask and the same eye shield. We change our gloves that might get contaminated when we're teaching the patient and things like that. But the same thing applies. We clean the rails of the bed so that the rails are at least decontaminated. We put a clean drape over the patient, completely clean, just a sheet or a drape over the patient during transport. So that's how we transport. We use the ICU ventilator to transport for the case. And so from the ICU, the respiratory therapist disconnects the ventilator and puts it on a transport ventilator. The transport ventilator comes to the OR. We use it in the OR to avoid disconnection. So we just hook up our oxygen to the main pipeline, and then the case goes on. When we're done, we use the tank from the transport ventilator and use that ventilator to go up to the ICU. And so the respiratory therapists usually wear a PAPR. They come in a PAPR for transport if we call them, because they have to switch the patient from the transport ventilator to the ICU ventilator. So for them, they wear it beforehand. That's fine. So that's kind of the workflow that we have.
Thank you so much, Dr. Betelehem Asnake. That was extremely informative and educational. I hope we get you in another session with the rest of the team as well. Thank you so much.
No problem. It was my pleasure. Thank you so much. Thank you.
እናመሰግናለን።
Okay.
እናመሰግናለን። ቻው።
እሺ።
It was a great presentation. Thank you very much. It was very informative and we'll apply all we learned here in our setup. Thank you.
You're welcome. Thank you for listening.
I think we're done.
Okay.